points in this presentation. The first is, given the wealth of data that is out there in the wild, how would we go about defining a phenotype of atrial fibrillation? Because these data are big. So in 10 or 15 million population-based cohort, this is the number of diagnoses, billions, lab values, prescribed drugs, diseases, and deaths. And the most important word on that slide is that there are methods and tools and scripts for you today to access these data. So you have the data. What do they look like? You won't thank us if we give you the data, because they look like this, a bag of bricks. And what you might thank us for is to give you organized data. How do we go from the raw data in the wild of electronic health records, whichever system they come from, into research-ready data that one can do useful things with? So, with atrial fibrillation, if you have international classification of disease data, it's fairly simple. There is only one ICD code. But of course, these are linked record data. There are a whole range of codes for procedures, different types of ablation. There are, frustratingly or interestingly, a whole different range of codes for procedures in primary care. This is SNOMED CT, an ontology which is international. And then there are a whole bunch of deeper, more detailed clinical codes in the primary care record data than there are in the hospital record data. And then, of course, there are the drugs. So how do you put this all together? Well, there's a process. It doesn't fall into your lap. So on the top left-hand corner, explore the phenotype, develop an algorithm, implement that algorithm, and then ultimately put it into the Calibre portal in a way that a researcher, a clinician, might understand the flow of the argument. I'm not going to go through these cells, but one needs to make that communicable, so that these phenotypes can be shared and used in a replicable way across Europe, across the world. And what the researcher sees is something familiar on a web-based portal. Next steps here would be to get at subphenotypes. So in ESC 2016 guidelines, here are some proposals, and these are to some extent tractable in the electronic health records. And I'm pleased to say that in 2017 we're going to launch the IMI Big Data at Heart initiative, which involves several colleagues in this room. I'm also pleased to say that the UK is part of a Horizon 2020 initiative. And this will be getting at big data across Europe, both, if you like, big in terms of number. You see that vertical scale goes up above 10 million, and big in terms of phenotypic, genotypic, and imaging depth, the horizontal axis there. So there's a range of resources. The circles are population-based resources. That's crucial for atrial fibrillation. The squares are disease-based resources. So I'm interested that I didn't see any representatives from these companies at this meeting. Maybe there are and I missed it. But it's important, the partnership with a range of pharma and biotech industries. So the second comment I want to make is, as we've just heard, how do we turn these data to good account in terms of guidelines? I'm not going to dwell too long on this, but just to give you a little bit of information of commissioned research by ESC that informed these guidelines. So across CHA2DS2-VASc risk, across primary and secondary care, separately in women and men, what does stroke risk look like? So here, the bottom row of that study is the Calibre finding, and it's different from none of the other previous studies have separated the data in that way. So here you see that both in men on the left and women on the right, the CHA2DS2-VASc score does what you would expect it to in 70,000 population-based cases of atrial fibrillation. Importantly, one has quite a consistent pattern in the higher risk patients in secondary care, in the blue, the top line there, than one sees in primary care. But still, the CHA2DS2-VASc score appears to separate risk. But the net clinical benefit, both in men here and women here, was what helped to inform the change of guideline recommendations that you've just heard about from John. The third comment I want to make is about big knowledge. How is it that we marshal the available published evidence on a question in atrial fibrillation? And I want to put a question to you. I'm thinking that most of you are involved downstream. Most of you are interested in what is this disease, how do we treat it? So I'm quite interested in how would we prevent people from getting this disease in the first place. So in order to inform that question, what's the available evidence? So conventional approach would be vertical, one risk factor at the time, and you would take a very long time to assemble reliable evidence. So we took an alternate approach, which was horizontal, to say across 23 cardiovascular risk factors, what's the evidence that in initially healthy populations they're related with the onset of atrial fibrillation. So here's something that you know already, but I'm just showing you to motivate you to look at the rest of this figure. So this is the overall summary of this field synopsis. You see that the risk factor age has been reported in at least 15 studies, some in consented cohorts, some in electronic health record studies, and of course it is associated, it's to the right of this vertical, positively, directly, with the incidence of atrial fibrillation. Each dot here is a study, and solid dots are significant studies, and the size of the circles relates to the size of the study. So no surprises there. Sex seems to be a little bit conflicting. I'm now going to show you the other 21 risk factors. If they're consistent, you expect them, the circles all to be the right for a direct association, or to the left, an inverse association of the vertical line. I think we do not know how to reliably prevent the onset of atrial fibrillation. I think there has not been a concerted effort to get to the bottom of the basic epidemiology. So let me give you one example here. Look at this total cholesterol and LDL cholesterol. Seems to be going in the inverse direction, possibly, for some of you, the opposite direction you might see. These are all small studies, 10,000, 20,000 participants. And let me show you how we summarize for each of these 23 risk factors the available evidence. So it's both a forest plot that you're familiar with an associated Swiss cheese plot, the Swiss cheese of the random and different and probably biased adjustments that people make in their studies. So these, if LDL was associated with the onset of atrial fibrillation, you'd expect all these estimates here to be the right of the vertical line. They are not. If the adjustments were consistent here, you'd expect a full set of circles here, and what you see is a set of Swiss cheese. So what does the, if you like, larger observational studies show, and how does that compare with the available statin evidence from randomized trials for lowering LDL? So in 500,000 initially healthy people, LDL cholesterol is strongly dose-response relationship with the incidence, I don't know, 10,000 cases of atrial fibrillation in an inverse direction. So lower LDL cholesterol is associated with higher risk of incidence of atrial fibrillation. To what extent is that consistent with the available trial evidence? And I would say it is consistent with the available trial evidence. So here, just to reassure you, myocardial infarction, here's the observational in red, and here are the trial associations, highly consistent. So I'm going to finish now and say that on the 13th of July 2016, we had a historic day in the UK. We got a new Prime Minister. I don't know why that's funny. It's extremely serious, believe me. We also got core funding for a new National Institute of Health Informatics. Thank you very much.
Thank you very much, Harry. Let's, as already highlighted, that the next presentation from Roland Welcome is not happening because of illness. So we are moving on to the next presentation. That's from Hein Heibeko from Belgium, who will tell us about the management of bleeding on anticoagulants and the official sanctioned ESC rule.